Let's start today's session. We're going to have the session on cardiac innovations and Trans-Catheter technologies. I'm with my co-moderator here, Dr. Warawong from Sirirat Hospital. I'm Man Chandavimo from Ramatipedi. We're going to have three interesting topics. I'll be the first speaker on the left atrial appendage occluder. Okay, so you already got my slides. So I'm gonna review on the update or the current status on left atrial appendage occluder occlusion or closure. I think the ขอสไลด์ไม่ชัดเลยครับ The slide มันมี interference เยอะเลยครับน้องช่วยดูนิดนึงข้างบนนี้มันไม่ชัดครับใช่ได้เหรอครับอ๋อโอเคแต่ปกติมันต้องไม่มีสีนะมันเป็นเงาสะท้อนต้องดูเราไม่เห็นเราให้ดูตรงโน้นครับโอเค Okay, sorry, I'm hallucinating. So, okay, so the guidelines for left atrial appendage, currently there's a guideline for both European and American. The European was since 2016, and as you can see here, left atrial appendage occlusion is a class 2B indication for stroke prevention in patients with atrial fibrillation who's contraindicated for long-term anticoagulant. Also, there's some diagram from the European Society of Cardiology as well, if that you're not mitral stenosis or mechanical heart valve and you had atrial fibrillation and your CHAD-RAS score is more than 2, and left atrial appendage occlusion could be considered if the patient is clear contraindication for oral anticoagulant class 2B, or if you already have a intracranial hemorrhage when you're on oral anticoagulant and you are contraindicated for oral anticoagulant, then you can consider left atrial appendage occlusion. So actually they have appendage occlusion had made into guidelines, but as you can see, majority of them are class 2B only, and the main reason is there's no randomized control data on this particular group of patients. The data we have was randomized data as compared to the patient who's eligible for oral anticoagulant, and that's why. Nonetheless, when we get into clinical practice, we realize that this is a viable option for a number of patients. As you can see here, this is a cumulative LA procedure done in the US. US FDA approved Watchman LA occlusion in January of 2015, and by Q1 of last year, there was about 55,000 patients done. So, you know, there's certainly, with the ongoing increase in number, means that there's a need for it. Why do we still want to close left atrial appendage? I just want to go back that 91% or 90% of the clot originate from left atrial appendage, and instead of treating these patients with systemic therapy, which means blood thinner that thins your whole body, we are trying to make it as a localized treatment. So trying to eliminate the appendage, which is a pouch, which usually 90% of the time is where the clot is originate. And also, in reality, also when you come to even yourself or your loved ones, the question is, who really wants to take oral anticoagulant for the rest of their life? And usually, that's a big question. We always prescribe oral anticoagulant to our patients, but actually, you know, no one wants to take it. And the next question that 90% of the time I got it is that, do I have to take it for the rest of your life? And unfortunately, our question is, as long as you can, yes, right? Another thing is, once you take it, what happens if you cannot take anticoagulant for whatever reason? You may be at high risk of bleeding. You may not bleed yet, but you are destined to bleed anyway, or you already have a serious bleeding. So at the end of the day, I think when you decide on patients' need for oral anticoagulant, it will be a balance between the effectiveness to prevent thrombosis or clot or stroke or emboli compared to the bleeding risk. But it's inevitable that you're going to have a risk come along with the oral anticoagulant. This is example is the patient who's take vitamin K antagonist. You know that at 2 years, 25% regardless of age, whether you're 70 or you're 90, 25%, 1/4 of them will have bleeding no matter what. So in reality, you know that oral anticoagulant had some limitation. You know that it's effective, but it also have to come with bleeding risk. It does not prevent all strokes, and hemorrhagic stroke in general had high morbidity and mortality as compared to ischemic stroke. We know now that in this era we have NOACs or DOACs, which is better than vitamin K antagonists, but remains an issue of compliance and cost. I just want to give you an example of a safest NOAC. This is a Aristotle trial, which is a randomized controlled trial comparing vitamin K antagonists and apixaban or Eliquis in patients with AF. And what they found was, despite NOAC is a winner as compared to vitamin K antagonists, but the major bleeding from this randomized controlled trials was almost 5%. And if you notice here, if the bleeding intracranial hemorrhage is much less in the NOACs group, less than 1%. But of these who had a bleed, 176 patients, almost 45% died at 30 days. So it's a rare incidence of bleeding compared to vitamin K antagonists. But if it bleeds, or if it happens, then people tend to die because the NOACs might be more effective and might be more difficult to reverse. So it's not a benign complication from NOACs. Another thing that important for this trial, this is the trials randomized NOACs with vitamin K antagonists, rivaroxaban, apixaban, or Aristotle I show you, dabigatran and doxaban. There was up to about 1/4 of patients who cannot take the medication for whatever reason. So study drug discontinuation remains high. So there's unmet need for stroke risk reduction in patients with AFib who can seek for other alternative treatment to long-term oral anticoagulant. Adherence is another thing. Despite taking once a day or even twice a day, adherence of this trial show that only 50% is being taken properly, and that has been associated with increased risk of stroke. You know, with warfarin, we can reassure patient by checking INR from time to time to make sure they're taking it. But and sometimes for NOACs, we assume that it's easier to take, no need for oral anticoagulant, no need for INR check. But in reality, they might not be as compliant or even worse than warfarin too. Whereas what happened with the left atrial appendage occlusion is that it's a one-time intervention that now got approved from the US FDA. As I show you, this is the Watchman device, which is the device look like this, and we more or less plug it into the left atrial appendage to obliterate the appendage. We also had other device form. This is the amulet device from Abbott. Had two lobe design, one lobe and one disc to close the appendage. So there's a few options of closing the appendage percutaneously. The procedure is relatively easy. The success rate is above 95%. The death rate from the procedure is very, very rare, almost non-existent. Evolution trials is real-world data, and despite that, the tamponade risk is about 0.3%, device embolization about 0.2%. So it's a relatively pretty safe procedures. When you look at patient-level meta-analysis compared to warfarin, compared to Watchman, shown that the efficacy was non-inferiority to vitamin antagonist. What is significant is the risk of hemorrhagic stroke, which is favor left atrial appendage occluder. Cardiovascular unexplained death is also favor left atrial appendage occluder, and all-cause death as well, major bleeding, non-procedure related. On top of that, as you know, usually if the clot originates from the appendage, it's usually a big clot, and that usually related to fatal or disable stroke. But from this patient-level meta-analysis, 55% reduction in big stroke, which is what matters. All these patients can stop warfarin at 1 year, majority of them, and the bleeding, as I show you. This is another non-indirect comparison that I showed you earlier, that the Watchman as compared to vitamin K antagonist had some mortality benefits too. In terms of cost effectiveness following stroke reduction strategy in AFib, this is done in the US, found that when you compare left atrial appendage occlusion to warfarin, time to effective is about 3 years, time to cost effective is about year 7, whereas NOACs about year 5 for clinical effective, and cost effective is about year 5 as well. So in bottom line is, when you compare to warfarin or NOACs, the therapy is more effective and less expensive, but usually need about 3 to 5 years to see it. Because as you know, when you take warfarin or NOACs, the cost keep increasing over time because you need taking the medications. How about, this is the data, I will not go through them, but this is the clinical evidence from left atrial appendage occluder. Quite limited randomized controlled trials at the moment, but a lot of single-arm registries that not only include Watchman device, but other devices such as amulet, lamprey, or wave-crest studies. How about in Asian population? We had opportunity to be enrolled in this WAPS registry, which had about 200 patients. Half of them were Asian, and about 70% 7 years old. And we found that for efficacy, stroke TIA or systemic embolization, expected rate was 8.5%, but the cohort or the registry showed that the effectiveness, the efficacy was 1.9% of combined this endpoint. So it's quite effective, 77%. When compare Asian to non-Asian, as this trial had some Caucasian population from Australia, we found that the Asian works quite well, if anything better than non-Asian population. Bleeding also the same, that the whole trials, 44 expected bleeding risk. From this trial 2.3, and for Asian is only 1.8. So it's worked quite well for both efficacy and safety for Asian as well. So there's at least some small data to suggest that for Asian population it works as well. Almost done. What happened with the upcoming trials? This is an important trials but difficult to enroll. It's called ASAP2. It's assessing Watchman device with 3-month step versus nothing or aspirin alone in patients who had atrial fibrillation who cannot take or unsuitable for oral anticoagulant. This one is being done so that there's going to be randomized data, and perhaps this can move the recommendations or the guidelines for left atrial appendage to be higher than 2B. There's also another trials called option trials, compared AFib ablation plus Watchman Flex compared to AFib ablation plus oral anticoagulant. Also Watch TEVAR, AS with AFib, Watchman plus TAVI or TAVI with medical treatment. Also there's new devices coming out on top of the Watchman and the amulet device. There's some Occluder, lamprey, or even Omega device. And there's a trials comparing amulet and Watchman devices. There's a trials on Watchman Flex compared to NOACs. So all in all, I think it's relatively not super active in terms of left atrial appendage occlusion trials, but still a lot of things going on, and hopefully it can give us more information. Also with the US data that they have been doing registry since FDA approved, so we will know more about long-term outcomes in the implant cases. So in conclusion, who might benefit from left atrial appendage occluder for today practice, in my opinion, the patient who had AFib, who had high risk of stroke, I think at least probably chat of 2, who also had high risk of serious bleeding or already had a serious bleeding episodes. Patients who does not want to take oral anticoagulant or had some limitation to take anticoagulation properly. Some patient who had stent coronary artery disease with AFib that had extreme bleeding risk for triple or dual therapy. And or this is a little off-label patient who had stroke or thromboembolic event despite being on therapeutic anticoagulant. At the end of the day, I think with this new technology, kind of we have to talk to the patient about pros and cons before we decide to put in the devices. Okay, thank you.
Thank you very much, Professor Mann. Any question? No. May I have one question? In your clinical practice, so how many % of the patient that you offer the left atrial occluders?
Usually I got a referral from either a general cardiologist or EP cardiologist. In Thailand, left atrial appendage occluder is not reimbursable yet, so we always get the patient who's has been taking oral anticoagulation at one point, whether warfarin or NOACs, and they have a bleeding. A good percentage of patients who had intracranial hemorrhage that recover, and they're very worried to go back on oral anticoagulant, or had some sort of serious bleeding that require multiple transfusion multiple times. So usually it's the patient who's relatively or absolute contraindication for anticoagulant. So it's a referred case, more or less. Yeah.
They need to pay themselves.
We have some foundation, so they have to pay part of it. They don't have to pay full cost. Nonetheless, we have to make sure that it's well indicated.
Yeah. Any more questions, please? If not, thank you very much.
Okay, thank you.
And, the next topic will be the TEVAR for the aortic disease, expectation and limitation. And this is my presentation. Good morning, ladies and gentlemen, and thank you for staying with us until the last day. It doesn't move. Okay. My topics will include the law of the TEVAR and modes of failure and future of the TEVAR. The history of the TEVAR is started by Dr. Huon Perody from US and in 1990, and then in Russia. In Ukraine, Professor Volodov also used the stent to treat the patient with the thoracic aneurysm in 1984. In our country, the commercial stent graft available in a few companies, and majority are tube graft. So when we start the operation of the TEVAR in 2005, we also use a tube graft to put in the patients. And then we have to apply the procedures with the tube graft to the various anatomy of the patient and also the many disease. From this slide, you can see the device itself is quite big. delivery system. The biggest size is up to 25 French, which is quite big when compared to the Asian femoral artery size. And the old day we use a portable C-arm to manipulate in the OR. The role of TEVAR. This is a descending aortic aneurysm, which is the ideal case for the TEVAR, and we start to do in this patient in the first few cases. And also, this is the first case that we put the stent in our series. It's a traumatic aortic injury, and the patient on the tracheostomy and also had the problem of the bowel and opened the abdomen. We put the stent in, then follow up CT scan, and up to 13 years, the patient is fine and still in our clinic. We also treat the patient with acute type B dissection by put the stent to close the empty site and put the SMA stent to open the visceral branch. We need to resect the small bowel for 2 feet, and the patient survived. We also treat the chronic aortic dissection at that time in 2007, before the guideline published. We don't know exactly what the outcome of this group of patients, but we discussed with the patient who is a doctor, and they're okay for the stent. So we do the stent and follow the patient until now. We also treat the infected aneurysm by the stent, and after a couple experience, we found that in some patients we got a good success, but in some we need to convert to open surgery. The patient with the aortic arch aneurysm, many images of the arch pathology include the distal arch aneurysm and also the proximal arch aneurysm. Our strategy to treat the aortic arch surgery is depend on the patient healthy. If the patient is low risk, we do the open surgery. If the patient is high risk for open surgery and the endovascular treatment is suitable, we do the hybrid at that time. If anatomical is unsuitable for TEVAR, we may apply the TEVAR by do the chimney or fenestate or hybrid or even medication. This is a total arch replacement, which is standard procedure for the aortic arch aneurysm, and we treat this operation, this procedure, to the patient who fit and healthy with a good outcome. If the patient unfit for surgery, we apply to do the arch debranching procedures. It depends on the landing zone of the aortic arch. This is example of the total arch debranching in 2008. We got some complication. For example, the retrograde type A dissection after the treatment, and we have to convert the patient. Up to now, we have more than 10 patients which have the retrograde type A dissection. Fortunately, we can save all the patients by the open surgery. This is proposed by Professor Bavria Group from Pennsylvania, and this is many types of the aortic arch hybrid procedures by combined open surgery and the endovascular treatment. Example of the complex thoracic aortic aneurysm. This is a 76-year-old man. He had the CABG done 15 years ago and very low ejection fraction. Then chest X-ray show widening mediastinum. The CTA show that the chori is patent of the vein graft to the PL and ramus intermediate and occlude of the lemma to rarity. And also show the distal aortic arch aneurysm 6.6 centimeters. What shall we do in this patient? Because he has a very low ejection fraction, to do the rhizotomy and replace the aortic arch aneurysm is really difficult. So we apply the endovascular procedures. This is a patent vein graft. So we do the innominate chimney and carotid bypass, carotid bypass. The patient survived for 6 months, and then finally he passed away from the heart failure. We do the comparison outcome of the hybrid surgery to the open arch surgery in our hospital. The number is in hybrid group is 40, in open total arch replacement at that time is 35. And we found that the long-term survival in the open repair is better than the hybrid, probably because the age in the hybrid group is older. And the freedom from intervention is also better in the open repair group. So at this moment, in the patient who had the aortic arch aneurysm in our hospital, we consider the open surgery first. Even the patient is borderline fit. If it's unfit for open surgery, we try to do the stent. We also do compare the endovascular procedure at the zone 0 and zone 1 TEVAR. We found that the in-hospital mortality is not big different between two groups. And the long-term survival is a little bit better in the zone 0. That means if we do the total arch debranching and we have a good landing zone, the outcome is a little bit better than the zone 1, which is a compromised landing zone. And freedom from intervention is a little bit better in zone 1, but not different. We found that the aneurysm size is effect to the mortality and freedom from the intervention. Another example of the patient with the aortic arch aneurysm, female, 76 years old. We thought that she probably a little bit unfit for open surgery. She had the aberrant right subclavian artery, so we do the total hybrid arch debranching and put the stent in. For up to 3 years, we found that the stent is migrate and caused the type 1A endoleak. So she came back with the big aneurysm at the aortic arch. CT scan showed the type 1A endoleak aneurysm bigger size. So we have to go back with the total arch replacement when she is older. Fortunately, she survived until now. This is example of the multiple aneurysm in the thoracic and the abdominal aneurysm. So we treat this patient by the endovascular repair with the fenestrate in the abdomen and the left subsequent bypass with the TEVAR in the thoracic part. This is another example of a quite difficult case. It's a chronic type B dissection, asymptomatic, but the size big, 6 centimeters, which is indicated for the surgery. He had a DIC, so we cannot do the open surgery. So we apply on the on-table fenestrate TEVAR, and the procedure is successfully. Even the small wound, he's got a hematoma, both groin. 6 months later, he developed back pain and found that there's a dissection at the distal side of the TEVAR. So I go back and put another occluder stent, we call the candy plug, in the false lumen, and then follow the patient. The CT scan showed that the candy plug is work well in the false lumen. But 1.5 years later, he came back with the back pain and the aneurysm size bigger. So we do the TEVAR at the distal end, and then plan to finish the endovascular procedure by the fenestrate or branch endograph. Unfortunately, 3 weeks later, he developed severe back pain, so we have to do the open surgery in this patient. I remove everything out and do the graft replacement, and also fortunately he survived until now. This is another complication in the dissection patient. This is developed after follow-up. We call the stent-induced new entry that is puncture to the intimal flap and cause the dissection. The theory is because the stent will go back, that use the term of the spring back effect to their straight tube and cause the dissection. To correct the problem is not difficult. We just extend the more stent into the landing zone. This is an example of the TEVAR in the type B dissection. We follow the patient and found that the distal end become bigger size. We have to finish the operation by fenestate and branch procedures. So the role of TEVAR, there's many aspects: thoracic aneurysm, acute aortic syndrome, traumatic aortic injury, chronic dissection, inflammatory aneurysm, and others, coarctation, connective tissue infected thoracic aneurysm. However, there's an indication published, the guideline in the HA guideline 2010 show that the stent have some benefit in some group of the patient. For example, the descending traumatic and complicated type B dissection. In 2014, the guideline also published the new guideline, and not much different. Also in 2017, the Society of Vascular Surgery of European country also published new guideline. Nothing much different. In some kind of patient like a acute complicated type B dissection, this is a class 1 indication. For acute traumatic injury, this is also useful to use the stent over the open surgery. But for the chronic dissection, the benefit is quite borderline. It depends at that center can do the fenestate or branch to complete the endovascular procedure or not. The stent design the company tried to develop the stent design to make the life easier in many kind of the design. For example, this at the proximal landing zone make it more conformability. The stent may be a small delivery system, more conformability, and also accurate to deploy. In China, they do the more taper stent to put in the type B dissection. Some kind of stent have the fixation, some kind have a very good flexibility, and some kind have the branch. Many branch design to do the more complex procedures. This is also the helical branch device. This is a stent of the type A dissection, which is we thought that it's not possible to do, but nowadays in high-risk patient in some center, they put the ascending stent graft to treat the patient. In the aortic arch lesion, there's a multi-center study, 70 patients from 14 centers. They found that the outcome is also excellent with the low rate of stroke. However, this is just short-term follow-up. And this is a stent at the ascending aorta. They reviewed from the 46 publication and found that the majority of the patient in the dissection patient and the pseudoaneurysm at the ascending aorta was treated by stent. The access is majority is femoral artery, and the perioperative complication is acceptable. And they found that the stent at the ascending aorta is have a acceptable outcome if we include the appropriate patients. The next will be the stent and the valve in the aortic root and the ascending aorta. Should be difficult, the most difficult part, but if we can do that, maybe the whole aorta can be stent. So in conclusion, the TEVAR provides standard treatment in some acute thoracic disease. Fenestate and branch graft become standard procedure in some center, and new device is ongoing study. However, the long-term outcome need to be monitored. Thank you for your attention.
Okay, thank you. Any questions? Okay, I have a quick question. For Thailand, TEVAR is reimbursable.
Yes,
right? And how does it work in terms of some complex cases? So everybody is doing them, or usually should be referred to a big center only? What would you recommend?
I think in some standard or if we follow the guideline, the outcome is better. But if we do out of IFU, sometimes the outcome is worse. So I think in complicated cases, probably you should refer to the experience center, the high volume center. Maybe we need to do more procedure, for example, the open surgery.
Okay, thank you.
Thank you.
So the next speaker is my colleague, Dr. Grisada Mimuk. He's going to give a talk on MitraClip for functional mitral regurgitation.
Good morning, ladies and gentlemen, and my great honor to be here. My today's topic is MitraClip for functional mitral regurgitation. I have 15 minutes. As you all know, functional MR is not a valve disease. It's a disease of the left ventricle. It's may caused by the focal LV disease like a ischemic MR or like a global LV disease like a patient with a dilated cardiomyopathy. Yeah, why the functional MR is important? Because as you can see on the left panel, they follow the patient with a heart failure reduced EF, and in the patient who has a severe functional mitral regurgitation at the median follow-up of 5 years, those patients has a worse prognosis compared to the patient with a moderate or mild functional MR. As you can see on the right panel, they follow the patient with a severe functional mitral regurgitation up to 2 years. More than half of the patient had died at the 24 months, and only 20% has improved in the symptom. We have two big randomized controlled trials published at the same month in the New England Journal of Medicine, but they show the very different result. The first one is a MitraFan study. They enroll the patient with severe functional MR, 300 patients, and randomized 1-to-1 to MitraClip therapy with the medical therapy or medical therapy alone. They follow patient up to 1 year. This is the result at 12 months. You can see primary endpoint, which was freedom from death or heart failure hospitalization. You can see the result is completely the same. The medical MitraClip therapy did not show the greater benefit compared to the medical therapy alone. In I think 3 weeks later, after the MitraFan study was presented at the ESC 2018, the COAPT study was presented at the TCT 2018. They enrolled the same patient with moderate to severe functional mitral regurgitation, but the different thing is in the MitraFan study, they can enroll the patient in the any state of the functional MR, but in the COAPT study, they had to push the patient on the maximum tolerated GDMT before enroll patient into the COAPT trial. And the number of the patient is more than in the MitraFan. In MitraFan, they had only 300 patients, but in the COAPT study, they had 600 patients, and the follow-up time is longer, 2 years in the COAPT trial compared to the 1 year in the MitraFan study. They randomized 1-to-1 to the MitraClip therapy with GDMT or GDMT alone. As you can see, the primary efficacy endpoint is the hospitalization up to 12 months. You can see MitraClip therapy in the green line show the reduction of the heart failure hospitalization up to 47% up to 2 years, and with the NNT of the 3.1, you treat only 3 patients, you can save 1 hospitalization up to 2 years. And also the all-cause mortality also reduced by the almost 40%. That means you can treat you treat the patient, 6 patients, you can save 1 life at the 2 years. This this is not a head-to-head comparison, but you can see the mortality reduction by the proven therapy of the heart failure if the ACI reduced by the 16%, and the new drug Entresto reduced by the 33%, beta blocker 36%, and device therapy like ICD, LCRT reduced by 1/4 or 1/3 of the patient. But if you look at the mortality rate reduction in the MitraClip therapy in the COAPT study, you can see the 42% reduction of the mortality rate up to 2 years. And also the MR reduction in the COAPT, you can see the baseline MR grade was class grade 3+ or 4+, but at 1 month after randomization in the patient treated with the MitraClip therapy, you can see that 92.7% of the patient had a MR grade 2+ or less, compared to 34% in the patient who on GDMT alone. They classify the patient into the MR, MR after the randomization. You can see that if the patient had a 3+ or 4+ ratio MR after the procedure, they will have the worst outcome compared to the patient who achieved a 2+ or less MR at 1 month. Why the two studies had a very different in the result? The first one, they talk a lot about this because in MITRA France study, they use the European criteria for the severe mitral regurgitation, which was the EROA only 0.2 is severe, but in COAPT they use a moderately severe or severe in the criteria. That's the EROA should be more than 0.3. Result to the EROA, mean EROA in MITRA France only 0.3, but in COAPT 0.4. And you can see in the table. And in MITRA France study, they allow the bigger LV to enroll in the study. You can see the mean LV/EDV in MITRA France study is 135 compared to the 100 in the COAPT study. And that means that in the COAPT study, they had more severe in mitral regurgitation and less severe in LV dysfunction. That might cause the outcome different in two studies. And also the GDMT, as I comment before, because in MITRA France study, they can enroll the patient at any stage of any state, like a patient did not reach the maximum GDMT, they allowed to enroll the patient in study. But in COAPT, they have a CEC committee to monitor the patient who had a maximally tolerated GDMT or not. If not, they advise to put the patient on the maximum, and after they cannot adjust anything, they are allowed to enroll the patient into the COAPT study. And also, as I showed you, the ratio MR is predict the outcome in the MITRA France study at the 1 year follow-up. The echo show the ratio MR more than 3+ is 17% compared to only 5% in the COAPT study. That means if we treat the patient well, like achieve MR reduction less than 3+, the patient will have the better outcome. And also, this is the novel theory that's proposed by Dr. Graben. We call the proportionate and disproportionate functional mitral regurgitation. We look at two factors like EROA that reflect the severity of the mitral regurgitation, and LV/EDV that reflect on the LV dysfunction. If we have a mitral regurgitation more than the degree of LV dysfunction, as you can see at the like a red panel above, we call disproportionate severe MR. This means the MR is more severe than LV dysfunction. If the patient is in the below the line, we call the proportionate severe MR. That means the MR is equal to the LV dysfunction or lesser than the degree of LV dysfunction. You can see the COAPT trial, the patient is on the disproportionately severe MR, but on the mitral valve is below the line. That might cause the difference on the result because the coap has a more severe in MR and less severe on the LV dysfunction. Next, I will show the case. I prepare 5 cases that we treat the patient in our center. The first one is a life-saving case. This we treat the patient for the live transmission CIT last year. This is a 73 years old male. He had a recurrent heart failure admission many times in past 6 months. Now NYHA class 3 and 6-minute walk like less than 300. She has multiple comorbidity like AFib, CKD stage 4, and there is a cardiomyopathy on the CRTD. She got the bivalent pacing more than 99%. And he had history of a subdural hematoma set up post-surgery. The echocardiogram showed the LV function of 22%, and LV is very big. And ELOA of CMR like 0.4. He has a severe pulmonary hypertension with PAP 68 millimeter mercury, and she was put on the maximum tolerated medication, including the beta blockers and tolvaptan, and he cannot tolerate ACI because the degree of the CKD. Now the SCS score was 4.6, and this is echo. You can see the echo show the LV function is very bad, and coaptation of the mitral is very bad, and MI is severe. We prepare to do a live case on this patient, but before the live case, he had a heart failure admission 3 days before the live case, and has a cardiogenic shock, need inotropic therapy. And a day before the live case, he had a worsening heart failure and respiratory failure and poor tissue perfusion. You can see the chest rate in the morning, and on the evening the heart failure is worse compared to in the morning, and he has a heart arrhythmia like a AFib with rapid ventricular response, and he need to put on the intubation and IABP and need a milrinone. You can see the blood lactate increased from 2.4 to 5, and now creatinine increased, and SCVO2 only 68. And now we calculate the STS score like a 24. Emergency heart team meeting in the morning of the day to do the live case. The heart team opinion is very highly for the MV surgery at this time and not suitable for LVAD. We proceed the emergency MitraClip therapy on the live case. You can see another challenge is echo, because MitraClip therapy we depend on the echo very much. But in this patient, the heart is very off axis. We cannot see the leaflet well. But finally, we managed to put 2 clips in a 1.5 hour. This is a result after the 2 clips. You can see the MR reduced to the mild MR. The second one is like definitive treatment. This is our patient, 53 years old male. She had recurrent heart failure admission in past 6 months. He has history of hypertension, dyslipidemia, and diabetes. He also has a HBV infection and early cirrhosis. The underlying heart is a non-ischemic cardiomyopathy, history of non-sustained VT. He got a CRTD for 6 years. He also put on the optimized GDMT, including intestinal beta blocker, MRA, and tolvaptan. He was listed on the heart transplantation in our center. While he waiting for the heart, he had heart failure admission again. You can see the hemodynamic data. The cardiac index is around 2. Sometimes it's less than 2. And chest rate show the heart failure cardiomegaly with a congestion. This is the echocardiogram. You can see the restriction of the posterior leaflet and CVMR. While we waiting for the heart transplantation, we discussed with the patient we can offer the MitraClip therapy as the bridging therapy to him. We managed to put 2 clips, and you can see the MR is now is just my MR. The beautiful of this procedure, you can see this is the picture of the patient just 2 hours after the procedure. She was lying on the bed and reading the book. And most of the patients can discharge home on the next morning. And now it's 6 months follow-up. He has no heart failure admission now in NYHA class 1, and he self-delisted from the transplant list. And the third case is a bridging therapy for the transplantation. This is a 69 years old woman. She was referred from Chiang Mai to our heart failure clinic for considering a heart transplantation. Underlying is a ischemic cardiomyopathy status post PCI of the LAD in 2013 and ASCVTS therapy. She was on optimal heart failure medication, and last CAG showed the patent LD stent. In 2017, she had multiple heart failure admission, and the echocardiogram showed the LV function of the 20 with severe functional MR. You can see the MR is long from the medial to lateral commissure, and LVEF is very bad, like at 20%. The ELA 0.42. We consider the MitraClip therapy as the bridging therapy for her because she did not listed on transplant yet because needs some workup, and we put 1 MitraClip, and you can see the result after the procedure compared to the before the procedure. The MI is reduced from severe to mild, and this is after the procedure. The heart still big, and after the 2 years of no heart failure admission, end of last year she had a heart failure admission again, and now LV function like a 20%. 15 or 20%, and she just got a new heart last week, and now she is doing well. The fourth case is a failure case. I showed the 3 of the successfully case, but sometimes the MitraClip is difficult. This is a 63-year-old female. She has a history of DCM with LV function like a 15%. She was put on the heart failure medication and a CRTP. She was followed up at one of Universal Hospital at the south of Thailand. And the echo showed the severe functional mitral regurgitation, and she was considered as a very high risk by the local heart team, and she was sent for MitraClip therapy. This is the X-ray. You can see the heart is big. You can see the echo show the very bad LV, like a 15% EF and severe mitral regurgitation. Because she had a CRTP before, the echo view is not very good. We try to put the clip in, but sometimes we cannot see the posterior very well, and we put 3 clips, but unfortunately, some clip like a torn the leaflet, and she has a severe MR after the procedure. And finally, after discuss with the heart team, they proceed surgical mitral replacement by Dr. Siam at our hospital. She was in the ICU for a month because she needed IABP and inotropic support. And after a month, she recovered and she can discharge home. And now 2 years after the surgery, she had no heart failure admission, and now NYHA class 1 or 2. And we function now is 25 to 30%. And the last one, I will show you the MitraClip therapy after the failed surgical mitral repair. This is a 55-year-old female. She had a end-stage disease on hemodialysis, and she has history of triple vessel disease, status post-CBG, and mitral valve repair 5 or 6 years ago. And she presented with a heart failure admission in our hospital. The echocardiogram showed a very severe LV cyclic dysfunction with a severe MR. The angiogram done, which showed the patent SVG2 LAD and PDA, and occlude SVG2 diagonal and OM. The native surgery is considered very too small to perform the PCI. We had a hard team opinion on her. They decided not to redo the CBG and MV replacement to this patient. This is the echocardiogram. You can see the LV function is like less than 30%, and MI is severe. We consider the MitraClip therapy because when we do the MitraClip therapy in the patient with previously linked annulopathy, sometimes the echo window is very bad. But finally we can put the clip in, and after one clip you can see the MR grade reduced to my MR. This is the before. You can see the CVMR reduced to my MR after the procedure. Now I think 3 months follow-up, she doing well and had no heart failure admission. In conclusion, the MitraClip for functional MR, I think we have the answer to question. The first, the patient is on the optimally tolerated dose of GDMT. If not, we need to put them on the optimal dose, and revascularization or CRT is already done or not. If not, we need to optimize it. And after we put on GDMT or device therapy, if they still have a symptomatic CVMR or not, if they still have the symptom and MR is severe, we can consider the MitraClip therapy. The next issue is the anatomy is suitable or not. The leafless grasping is appropriate, and is there room for the clip. Usually we have to have MVA more than 0.3 square centimeter to put the clip in. And this is my conclusion. The functional MI is a disease of the LV, as we know. First, we had to treat the LV dysfunction first with appropriate medical therapy or device therapy. And we can consider MitraClip when the patient still had a persistent severe MR after the appropriate treatment, including the CRT or PCI. And this therapy could be the definitive treatment for the patient, bridging therapy for the heart transplantation, or the treatment of the recurrent mitral regurgitation after the MV repair. This is the data from our center. You can see that we have the 42% of functional MR. The male is half, and median age of our patient was 27 years, and mean ATS score was 9.5%. You can see the success rate is almost 100%, and very low complication rate. And in the elective patient, you can see 100% of the patient can discharge home. If we go back to the proportionately CVMR graph in our center, we had the patient is very disproportionately CVMR. That's why we had a very good result on our program. Thank you for your attention.
Thank you very much, Dr. Kisada. Any question, please?
I'm interested in your the disproportionate mitral regurgitation. Even though we label all these patients as LV disease with functional MR, but most of the patients, I think there's still mixed component of the mitral regurg. So those cases of this disproportionate mitral regurg, they may have something that is correctable. That's why the COAP study might get a better result than the the other one, which are very in stage of the LV dysfunction. What is your idea about that?
Thank you so much. Yeah, I think so too, because when we look the patient with a functional MR, most of the patient is not the pure functional MR. Sometimes they have a problem with the leaflet also. Sometimes we call the functional, like a DMR plus functional, that we can, if we treat the patient, those patient with a disproportionately MR, we can, that the result should be more better than the patient with the pure functional MR with a very severe LV dysfunction.
May I have a question? By anatomy, how can you select the patient to do the MitraClip?
Yeah, we depend on the echo finding too much. Like we need to have, like I showed, we have to have the room for clip at least 0.3 square millimeter, and the leaflet should be like quite healthy, no calcification, or the MAC is not so severe, and echo window should be good enough to put the clip. If we have the artifact on or shadow on the leaflet, we cannot see the leaflet well. We consider it's not suitable for the clip. It depends on the echo finding.
And how you can evaluate the quality of the leaflet? Because I have one experience to remove the MitraClip and do the MVR. We found that there was a hole in the leaflet, not at the clip area, because probably from the tension or something.
Yes.
It's quite thin.
Yeah, we just have the new device that we call XTR, that the leaflet, the clip arm is longer. We found if we put on like a functional MR, that very big LV or big annulus, the leaflet tension caused by the clip, the new clip, the longer clip is sometimes is greater than the small one. That may cause a leaflet injury. That we know if the LV annulus is very big, and we should not put the longer clip arm, because sometimes the leaflet tension may cause like a tearing of the leaflet, like you see it before.
So we expect to see that the longer clip may less stress on the leaflet, right?
No, the longer clip is a much stress on the leaflet, because
That may cause the more leaflet.
Yes, some operator thought about that. Sometimes the longer clip arm, because the tension of the leaflet with the clip is much higher than the small one. Since sometimes if we have like a very large annulus and the coaptation length is big, sometimes if we have to put the clip more than 2 or 3 clips to put the leaflet together, and if we put it too much, sometimes it may cause the tearing of the leaflet.
Any more questions, please?
Okay, then, so thank you very much for this session. I think it's, I'd like to adjourn. We're going to have a coffee break and then come back for the oral presentation on aortic. Okay, at 10:30. Okay, thank you very much.